neurodevelopmental treatment. And it originated by the Bobats. Carl, the husband, was a neurologist. His wife was Berta. She was a physical therapist. In the 1950s, there was these people, or an approach called the Domain Delgado approach. And they did something called patterning. And they would lay these kids with CP on the bed and kind of like, you know, move their legs back and forth like in cross patterns kind of stuff. Kind of like PNF. And so they were like, well, that's one approach, but there's more to it. You have to handle people. And so a lot of the concepts that maybe you talked about in Susan's class about the development of normal movement kind of came from the Bobats, studying kids and later adults with CP or stroke. It's obviously based in neurology, neuroscience, but they describe neurodevelopmental treatment as a living concept, meaning if you went to an NDT course 20 years ago, it's going to be way different than an NDT course now because we continue to learn more about motor learning and motor behavior as we learn more about neuroscience, really. So the concepts are, of course, that, you know, the whole purpose is to develop functional movement, right? We could improve a person's range of motion in linear planes, but most movement doesn't occur in exactly the sagittal plane or the transverse plane, right? Most movement occurs as a combination of a bunch of movements, as a combination of a bunch of planes of movement, okay? And so some of the key concepts are, and you may have learned this with Susan, especially a baby, we have to have stability before mobility. So I could have a functional hand, but not have a stable shoulder. Well, I'll never be able to have function until I have more proximal stability. And that doesn't mean, the word development in this approach, it doesn't mean that just because somebody has to have one movement before you start the next. So we can overlap phases of development of movement, okay? So it doesn't mean somebody has to have the perfect ability to be prone on all fours before you start doing superimposing movement on that. But it is a key concept to look at. So if a person is having a problem moving, you want to look, do they have a stable base on which to move, okay? So we actually videotaped for a hippotherapy research project yesterday, and I said to the physical therapist, well, how would you describe her tone? And we know with kids with CP and adults too, with neurological impairment, that you could have like a mixed tone pattern, right? You could have like a floppy trunk, like her head was like this, her pelvis was just loosey-goosey, but then the limbs were hypertonic. So she's hypotonic in her trunk and hypertonic in the limbs. So we've got to get this kid to have a stable base before we're going to get any quality of movement out of her. Does that make sense? So that's why a lot of therapists, particularly with kids, get into that suit therapy. Have you all seen that being done? It's like you put a kid in a cage and there's all these rubber bands you hook to this like spacesuit looking thing. And basically what you're doing is strengthening their proximal core. You know, I like that word. You're strengthening the core so that they have a stable base on which to do distal movement. Does that make sense? Okay. So a lot of the things that we're going to talk about are how do we provide stability, mobility. How do we look at synergistic movement? And if you've read some of this material and you looked at Brunstrom, and you will see eval forms that talk about Brunstrom. And Brunstrom described how, after like a brain insult and people are hemiplegic, Brunstrom described how movement kind of recovers. Now, I just want to say that's a generalization. And I don't know this for an exact fact, but it has been my clinical experience. I don't know the research, so don't quote me on it. But with people who have a stroke or a brain injury that involves a bleed or a hemorrhage, they tend not to have the typical recovery pattern. In fact, what I have seen clinically is they tend to recover the hand before they recover proximal strain. Whereas most strokes are thrombosis or embolytic in nature, a clot, okay? And so you have ischemia happen, right? Blood vessels clog off, you lose blood to your brain, and then you have a stroke. Those ischemic kinds of stroke typically will follow this flexion synergy pattern and extension synergy pattern we're talking. And the typical extension synergy, Jenny, you might want to get this on tape. So is the upper body has a flexion synergy, right? This is the extreme, right? Where you rotate it at the shoulder. Let me kind of move over here. Where you rotate it here and you go into flexion. Okay, you retract it at the scapula. And then it's almost the opposite in the lower extremity where you go more into extension and external rotation. Okay, so you've probably seen people who are hemiplegic really bad and they do this kind of gait. Okay, so what happens is initially someone has a stroke and they have no movement, so they're flaccid in the beginning. And then gradually the tone starts to build up where the extreme would be this, okay? And then our job as therapists is to break them out of that synergy, okay? And that's the hard part because people want to move. So in order to move, we'll move any way we can without respect to quality of movement. Think about you, if your leg falls asleep, right? You sat on your legs on the floor for a little bit and your leg falls asleep and you get up to move. You don't wait till it wakes up, right? You go like this for a couple minutes and you shake it, you do whatever you can to move, correct? Okay? Patients do the same thing because they want to be able to move. They want to be able to do for themselves, okay? The other thing is we're dealing with graded movement. So small movements, we'll practice it over and over in NDT. We'll just like practice a weight shift. Feel it. This is the way your hips should feel during weight bearing, okay? And we'll do gentle contacts so we know that they're feeling the right amount of pressure. We'll give them a little pressure. So through our handling, we will give them graded movements. Now, philosophically, NDT believes that you should always work both sides of the body, okay? You should not ignore the unaffected side because, you know, we don't learn to move one-sided. So normal movement is based on bilateral movement. Normal movement generally proceeds, what's this, cephalocaudal, right? So you have to have head control before you're going to have control of the trunk, right? You have to have proximal movement before you have distal movement, those kinds of things. The other thing in NDT is we've got to get these abnormal reflexes under control. So if I have an AT and R that gets in the way, we've got to put people in positions that inhibit those abnormal postures, okay? And a lot of times, you're trying to get people in a position where they can be more relaxed. So, say you have somebody with a brain injury that has a startle reflex, right? You know, they go like this, and they do that AT and R and Neuro startle reflex. So you're gonna maybe get a headrest that puts their head a little bit forward to inhibit that from happening. Does that make sense? So with NDT, to me, is with any OT, assessment and treatment are always overlapping, that you are always assessing people as you're working with them. If you're not doing good therapy. Yes, Jenna?
When you're inhibiting the abnormal tone, isn't that painful for them?
Well, you're not like pressing on them. You're trying to put their body in positions where their tone can kind of relax a little bit. So side lying, if I go into this extensor retraction kind of pattern, if you put me in side lying in a little bit more of a fetal position and you put like a wedge behind my back, I'm not going to do this as much. So a lot of it's about positioning to inhibit the reflex, not yanking on their arms. Okay, good question. Okay, the other thing that's really important here is this 5th point down. It's a little harder with adults. With kids, you could just get them involved in play. But with adults, first of all, with adults, we've had normal movement typically. So it's almost harder for us to learn a new way, whereas kids never had normal movement if they were born that way. So it's like with adults, you have to unlearn and relearn movement. And this is difficult. How many of you have tried to learn a new motor skill? I mean, I go to karate, and there's one particular teacher, bless his heart, he's very nice, but whoa, he gives way too many verbal commands. And the master, the owner of the place, he's a really good teacher. He'll say, stand right behind me and do what I do. And there's no other verbal command. You know what I mean? Whereas this other guy, Alan, he's like, well, what you have to do is this, and then you do this, and I'm like, Alan, shut up. I don't say it, but I think it. You know, like, just stop explaining and make us do it. And this is a concept in NDT and in motor learning. Less talking is better. And we women have difficulties with this, do we not? You know, not that guys don't, but girls are much more uncomfortable with silence. It is difficult to feel something kinesthetically if you're focused on listening. So sometimes it's like, let's just feel this movement, and that's it, okay? Also, with the kid, you can disrobe the kid and look at their scapula. Whereas an adult, if we were like in this environment, they're going to be uncomfortable being disrobed, especially a female. Again, functional activity in terms of OT must be meaningful to the patient. And that's what Jan Davis is trying to get at in her videos. What activities do these people normally do, and how can I do that activity but still give them some facilitation and cueing so they know where their body is in space. And hopefully you remember what I said probably the first class. Upper extremities in particular are harder to recover because we don't weight bear on our upper extremities. So the first rule to me, whether somebody has low tone or high tone, is if you can do anything to get them in weight bearing, you've got your number one technique in your toolbox. Weight bearing, weight bearing, weight bearing. Weight bearing with placing, like this, like rapid kind of placing, is better for hypotonic people because it sort of jerks them into eliciting tone, like a quick stretch reflex. People who are high tone, you want to do slow, controlled weight bearing. So the weight bearing is a little different. The speed, the force, the duration might be different depending on whether people have high tone or low tone. Now, I've already said these things, but these are general movement patterns. Weight bearing always precedes movement, so that's why I said start with weight bearing. Again, these patterns or motor milestones can overlap one another. We don't have to be perfect in being prone on elbows before we try to be quadruped, okay? So we should start people a little before we think they're ready to try that next movement milestone. Also, movement is dependent on force couples, and this is the thing I really learned in NDT, is that, you know, we might think that this is a flexor problem, okay? The flexors are too tight. But what's also going on is the extensors are too weak and they can't override what's going on here. So anytime you think flexors, consider what's going on with the extensors. Anytime you think of abductors, think of adductors. Internal rotators, think of external rotators, right? So those are our three force couples for all movements in our body with the extremities, okay? Rotary movements don't, well, yeah, I mean, you have internal rotation, external rotation.
Dumb question. If somebody's stuck in a contraction and you're trying to see if it's the antagonistic muscle,
Right.
right? How can you tell if it's the contraction versus the antagonistic muscle?
Great, great. Okay, so what you can do is make them go against gravity with the antagonistic muscle. So if somebody has flexor spasticity, I'm going to lay them on the mat, I'm going to put them up this way, and I'm going to support their upper arm because they probably don't have stability, and say, can you push against gravity? And I'm going to see, is there any tone in the triceps, okay? If I get nothing out of the triceps, I know I better work on triceps as well as relaxing the biceps.
So if you see them trying, and it's not moving, but you see them trying.
Yeah, you might try some electrical stim with the triceps to strengthen it, okay? You might try some vibration, tapping, those kinds of things to get the weak muscle moving, and then do something else to relax the spastic muscle, okay? And we'll talk about that in a second. Movement proceeds isometric, eccentric to concentric. And most of the activities that we do, right? Functional activities using objects, more often than not, are concentric activities. So we've got to do some weight bearing before we go into using our arm or our leg in a distal way. Does that make sense, guys? Jenny, you okay with that, girl?
Are you saying that the movement we have starts, like if we do a movement, it starts with an isometric,
The last one.
then,
No, not each movement.
oh, okay.
In terms of most functional things here, this is a concentric movement. What can you do in this kind of movement? You can't do functional crap in this way. So most functional activities involve concentric, the most complicated movement, right? Standing is easy because it's fairly, static, right? Kind of a lengthening contraction. Walking's a little harder. We got more concentrics going on in walking. But using your arm to do an occupation essentially requires that highest level of movement, which is dependent on the two before it. So we shouldn't just try to work on concentric activities. What I like to do when I work with a patient is we start the movement session with weight bearing, then we go to lengthening activities, then we go to concentric. So kind of a developmental or hierarchical kind of progression, okay? And then lastly, movement occurs in a variety of planes, okay? So, okay, now I'm telling all of this now, it's on tape. If I ever go in your clinic and see you doing the upper bike, that little thing, strapping a patient's hand to a bike, the thingy, the pedal, or I see you with a pulley and strapping the patient's hand to the pulley, number one, you're doing damage probably to their joints, and secondarily, they're exercising in linear planes. It's not teaching them anything about motor control, okay? Most movements that we do are diagonal, rotary, okay? Huh?
There's weight bearing.
It's not weight bearing, it's traction.
Oh,
It's yanking your joint out of the socket, okay? If it was presses, I could argue, you know, have a patient do a push-up, have at it, that's fine. Okay, that's weight bearing. That's compression. That's gonna give me proprioceptive feedback about where my joint is in space. But if you do traction, that's gonna cause damage and not give me as much feedback as weight bearing will. That make sense? Okay? All right, so these principles are really, really important to know. Now, we've already talked about, we'll talk about the stages of recovery, talked a little bit about that. But when we assess a patient, we want to say, what movements do they have available? Kind of like a strengths-based approach. And remember with Ruth, in the video with Ruth, we said, okay, she has scapular elevation, she has a little bit of retraction, she has a little bit of shoulder extension, and maybe a little bit of biceps. That's it, okay? But there's probably nothing distal to that that's active movement, okay? So you want to say, what do they have that I can work with? Well, she's got scapular movement, so let's strengthen the scapula because that will become the proximal base for distal movement. So how can we strengthen her scapula? Yeah, wall push-ups. So sometimes I'll go to the dollar store and buy, you know, like that tacky kind of shelf paper, put it up on a wall, put it up on a table, okay? And have them just lean over the table. Use their other hand, if their hand is kind of contracted, use their other hand to weight bear on it.
a coconut exercise?
Yeah, yeah. Now, with old people, unlike kids, with kids you can get them over the ball, you can get them in quadruped, you can put them under a bolster. You ain't going to find too many 80-year-olds that are going to lay prone, okay? They're not going to lay prone. So it's much harder with old folks or people with respiratory problems to tolerate being on their tummy. So you may have to do it modified in standing, wall push-ups, those kinds of things. So,
What about the joint compression?
like you would do with the kid? Yeah, you could do that. Lots of times there's a technique, if you'll give me your arm, just this one.
Wait, I can't
called,
see.
like in your floppy, okay? Your floppy, you have high tone. It's called place and hold. So I let it go, and then I push it in, kind of. So I'm giving him feedback about where his limb is in space, okay? Place and hold is one NDT technique, okay? Now,
She is strong.
I'm strong in some ways, but not in others. Okay, so you remember I talked about Brunstrom stages. NDT talks about a similar concept. So this is how motor return occurs after we have a neurological insult. Right after you have that stroke, usually for about 72 hours, you're completely flaccid, no movement. Then after a few days, we start to see, this is the typical pattern in the upper extremity, some tone in the biceps. Now if that tone in the biceps isn't balanced out by the triceps, you know, people want to move so bad, they'll move however they can. And they operate their arm kind of like a crane, if you will, right? So you will see, usually in the upper extremity, hypertonicity, and in the lower extremity, you'll see some hypertonicity too, about 72 hours after the brain insult. Then, depending on the rehab that happens, you know, other medical factors, people will go into a mixed situation where they have floppy flexors or floppy extensors and hypertonic flexors, or, you know, a floppy or flaccid tone in the trunk and hypertonicity in the extremities. So, you know, you'll see different things. Now, the stage of relative recovery When we talk about relative recovery, it's where people begin to be able to isolate movements at individual joints. So now, when you tell me to lift my arm, this is still kind of a synergistic movement, right? And I put it up on the table, okay? When I'm in relative recovery, I might still have a little synergy, but I can move my elbow independent of my shoulder. I can move my wrist independent of my elbow. So I can isolate movement at individual joints. And that's one of your goals in therapy is let's block one joint so you can move the other. So you may see a therapist using, I do this in home health, where I just bring swim floaties and block the person's elbow and say, I just want you to lift your shoulder. So they can just strengthen the proximal shoulder instead of moving like this. So my goal in using the blocking little swim floaty so the elbow doesn't bend is so that they can isolate the shoulder.
That's cool.
Okay, simple technique. And then I might block the wrist, put the swim floaty down here, or put a splint on them or something, and say, now I just want you to move your elbow. And I might stabilize the shoulder. So they can learn how to move at each joint. Same thing with hip, knee, ankle. Okay? Okay. Now, some patterns of motor return are you could have low tone, no ability to initiate movement, and subluxation. I'm assuming you talked about subluxation when you talked about strokes, maybe, but it is very common in the shoulder. You may have talked about it in Chrissy's class, anatomy, way back when. Now, again, remember that the hip joint is a ball and socket joint. So if I weight bear on the hip, I'm in a nice contact with the acetabulum, right? That nice round joint envelops the greater trochanter, okay? But remember, our shoulder is not a true ball and socket joint. So if I don't have my scapular muscles holding it in, it just droops down and we get subluxation. Subluxation, you'll be able to feel a dent to the side of people's arms. Well, they'll complain of pain if they have some sensory awareness. But usually we measure subluxation in fingers. So 4 fingers would be a severe subluxation. Usually it's 1 or 2. Okay? So what we want to do is support people so that we push it up into the socket. Let me say this, in NDT philosophy, slings don't do crap. Okay? They put people in slings and x-ray them. And while it appears here they're in this sling, it doesn't do anything to push the shoulder up into the socket. Likewise, those little foam blocks that they put on the side of the wheelchair, they don't do anything either. The main thing to reduce the subluxation is we've got to develop scapular muscles. So they pull it in. Okay? So weight bearing. Okay? E-stim. Things that will get those muscles working are the best things possible.
So per NDT approach, we have to put them in the sling to do something as far as pain. But as far as for therapy interventions, you want to do weight bearing activities.
Yes, yes. The sling sometimes helps with gait because otherwise they would be like this. So the sling kind of puts them upright. It makes their gait a little more symmetrical. I just don't want you to be fooled to think it's aligning the shoulder joint. It is not.
And that's all you see.
Yes.
All the time.
Yeah.
They're either that or the one that.
Right. They're just horrible. The best ones, though, are the figure 8 slings that really you don't see them under, because they're under clothes. And they crisscross in the back and they just put them under here. Or there's something called an orthokinetic sling that is like a figure 8 that you wrap around here. And then you put like a little strap here and Velcro their hand to it. And as they walk, it bounces and it causes some quick stretch reflex is really what it's doing. And elicits motor control. It's one theory. Okay? Kinesiotaping again around the scapula will give it feedback about where these muscles are supposed to go and in what alignment they're supposed to move. So kinesiotaping will, to me, be much more effective than a sling.
I don't see it too often anymore, even though I know it's.
Right, right.
I don't really see it. Is it because of elderly people just put the tape on their skin?
Yeah, the tape is bad. Now, kinesiotaping is a tape, you put a rigging tape on, and then you put the kinesiotape over it. So you put 2 layers of tape on people. And with old people with thin skin, you know, you're at risk to cause breakdown.
There's some improved brand though that we uses and it causes no irritation and it goes
Great.
on and off really, very expensive.
Have you seen good results with it? Yeah, yeah. So I would suggest if you are working a lot with neuro or ortho patients, to go to a course in that, or, you know, ask your PT. I mean, they get it probably in school. For us, it's a little more of an advanced practice skill, okay, kinesiotaping. Now, this is really important. As people develop movement, sometimes they get this unbalanced motor control, where they're weak on one side of the joint and hypertonic on the other side of the joint. And what you see sometimes is spastic kind of scapular elevation, so that the humerus actually is jammed up into the, right under the acromion, so that when you bend them, they just scream in pain. So how do we fix this? So that they get better range of motion and it's pain-free. How can you do that?
You have to line up the shoulder.
Ensure that the ball is soft.
Okay, how do we get it in there so, do you remember the greater tuberosity doesn't hit the acromion? It's way back to kines, right?
Yes, you get the gravity eliminated first.
Okay, gravity eliminated for sure. Do you remember us talking about, or maybe Chrissy talking about, like how do you get, particularly in old people, right? I'm already kyphotic, right? Head forward. I'm not going to get beyond here. But how will you get me to get more range of motion? You know, Heather?
Mhm.
Say it.
Lay him down. Get him supine.
Because then they won't fight
They're
gravity.
not
That's
flexing.
true.
You're getting rid of gravity. So
Right, but
gravity
you
eliminated.
haven't fixed the fact that the greater tuberosity
Oh, you're
is
still talking about the
Internal rotation,
external.
external, okay.
Good, you're on the right track. So if we externally rotate, now that greater tuberosity is not hitting the scapula. So you say thumbs up, and then we go up, and we'll have more pain-free range of motion. So that's something to think about too. What position is this person in, okay? Do it this way, palm down, then do it palm up. It's much easier, okay? Or thumbs up, I always say. Okay, same thing with abduction. Do it palm down, you can't get as far. But if you do it palm up, you can get much more range of motion. And all you're doing is rotating the humeral head so that the tuberosity doesn't hit the acromion, right? So it is all about positioning for the best quality of movement and most pain-free, that is. Okay, so let's talk about when we look at somebody's movement, okay? The first thing you want to look at when you look at a patient is how is their head aligned. So if I have a stroke and I'm sitting in my wheelchair and I'm like this, okay? Putting my arm in my lap is not going to do me any good if I'm like this, okay? Usually, if the head is positioned, the body will follow, okay? Keith, come here. I like doing bigger people. okay? So we have to think, what are my key points of control? So where could I control Keith? He's a big guy, let's assume he has spasticity. How am I gonna move him to get him to do what I need him to do?
Go low, get on his hips.
Hips is a key point. Pelvis, okay? So if I could tilt the pelvis, make the pelvis go up or down, rotate the pelvis, I'm gonna get better quality movement out of him. Where else is a key point of control? Head, okay? So how do I hold the head?
Can you
With
move
your
that?
head, because your hands are going to be on his hips, so your head's going to be on his
No, put your feet like this.
Sarah.
Okay,
Can you
so
move that
Keith,
lunchbox?
I want you to stand up, 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 oh, he's not doing it. Keith has low tone, there we go, okay? And sit back down, okay? And up, and back down, and up. I'm not doing any of the lifting. Keith is doing all of his muscles. All I'm doing is cueing him. We want to go this way and this way, okay? Great point of control. Scapulas also. It's a little harder to get scapulas to move though. And give the right feedback. Do you see? And back down. And up. And back down. Okay? So my hands are going like this. When I did his head, I was going like this. So do you see the dance we're doing? How about this? We're going to come up, and then we're going back down. Come on up, and let's go back down. Up. Okay, this time we're going to walk. Come on. And you try not, you don't pull too hard. Come on, your pelvis, okay, and, okay? Let's go back. Okay?
So,
It's handling through your hands. Pelvis is much harder. Sit back down, okay? So it's hard for me to get in here. Get to the edge of your chair, if he could do that, the patient. You can't get hold of a pelvis. It's hard. Until you get people up. That's not what he said. So I might have to be here. Say if this is his hemiplegic leg blocking it, somebody would be behind him, probably. Come on up, and I'm going to move my hands like this. Because when he comes up, he kind of tilts posteriorly. When he sits down, anterior. Okay? Up, up, and back down. Up, and back down. And notice, when we do these movements, and I'm just getting him to do gentle weight shifting, I don't go full range of motion. Making people work in the mid-range of motion is actually more effective. So, let's try his knees. Come on up, and back down. Up. You should start doing this in your physical training with people. Up, and back down. Up, and back down. Up. Come on, come on, come on. So all I'm doing is this way and that way. It's all about my hands. You could even do it in the feet. Come on up. Stand up, and back down. Okay, up, and back down.
I'm like,
Okay? Now, that would be a high-functioning patient.
I was
You
gonna say,
could
what are you
just-
gonna do with the pusher on a walker in front of him? Because
gonna
this
deal
happened.
with the
This
head
happened on
first.
field. Well, this happened on field work. She was
Mhm.
pushing, and they were trying to get her to come forward, and they were just pulling her, and she was pushing even farther. So I walked up to her and put
Yeah,
my hand on her chest,
and this
and I said,
reminds
"Come
us-
here to me, come here to me." And she went, and the physical
Uh-huh.
therapist looked at me like, but I was like, "Well, but you got to
Yeah.
tell her where you want to go." But
Uh-huh.
that, I mean,
So
what else
that's
could
like
you
this,
do?
too. You could use two hands, up and back down,
Because she's this, and
Okay.
she thinks she's
Up.
standing up.
and back down,
So
Oh,
what
no,
you
well,
do?
no, no,
What
no.
you have is
okay?
I put my hand here so she would come forward. She's
Well,
doing
you
this.
can
I'm
do it
like-
with any
she
part
thinks
of
she's
the body.
standing up straight. She's
Okay.
like this.
Any part of the
We
body.
wanted her to.
But if he's a person who does this, well, I certainly want to move him in a flex position to inhibit this reflexive activity.
You put your hand in front of it.
Over and over, so
I
he gets
touched
the
her chest.
feel
Come here to
of
me.
just that small graded movement. What is it supposed to feel like? Then, and I add something to it after about the 5th repetition. Okay, now let's reach out for this power aid. Okay? So you practice the movement over and over, and then you add function into it, okay?
Samira, you put your hand on back and front and just.
You could do it both ways.
Okay.
Okay, think about yourself as sculpting and giving, remember, you got to remember your anatomy. Well, how do muscles work? Well, they shorten and lengthen, so you're cueing them. This is the way the movement is supposed to feel, because they've lost that sense of
Yeah.
how the muscles are supposed to work together. Does that make sense? Why don't you pair up and try this on each other? Try to facilitate your friend into standing and sitting from the head, from the pelvis, from the knees, and from the feet. So you could turn off the video.